I'm Marilyn Priel. Welcome to the better part. Vascular surgeon Dr. Polyxene Kokinos is here with us to help us learn more about our vascular system.
Welcome to The Better Part, a program by and for seniors and devoted to exploring the many facets of those better years of our lives. The name of our program is inspired by a quotation from Robert Browning. Grow old along with me, the best is yet to be, the last of life for which the first was made. Now, sit back and enjoy a program made especially to provide seniors with useful information, plus some lighter moments to brighten your day.
Dr. Kokinos, thank you so much for coming in. I know you were very busy this morning at the hospital giving a lecture on actually a new procedure that you have for blood clots. So I think what we need for you to do first is tell us about the vascular system.
Well, Marilyn, thank you so much for having me here. The vascular system consists really of all the blood vessels in the body. There are three main types of blood vessels. Arteries bring blood to organs and to the legs and arms and head. The veins bring the blood back to the heart. And then there's a third circulation system called the lymphatic system, which is the least known of and about, which brings a viscous fluid back to the heart.
I've been wondering about that lymph system, how it gets in. Does it get into the veins and the arteries, or does it have its separate little channels?
Yeah, it has its separate little channels, and people really don't know too much about it until their glands are swollen, and those little glands are actually lymph nodes. So they're like way stations where the little lymphatic channels feed into, and those vessels or channels get bigger and bigger until they actually empty via something called the thoracic duct directly into the heart, just like the big veins do. There really isn't that much surgery with lymphatic vessels, but there is a fair amount with both the arterial system and the venous system.
Now, there's some terminology that is used, and maybe you could explain that for us. Like, what is an aneurysm?
Well, an aneurysm is a weakening of the wall of a blood vessel, which under pressure, because all blood in vessels is under a certain pressure, that's how they measure your blood pressure in your arm. Under that pressure, the vessel dilates over time, and so it becomes like a balloon in the middle of a straight tube. As that balloon gets bigger, there are complications that can arise from that. The most feared complication generally is that balloon just ruptures. So just like a balloon will pop as you blow it bigger and bigger, an aneurysm will pop. Unfortunately, the difference is a balloon is generally filled with air. An aneurysm is filled with blood. And when the main types of aneurysms that are in your abdomen rupture, it's like turning a faucet on full strength of just blood pouring into your abdomen.
And then, of course, the blood doesn't get back where it should be. Is that a secondary problem, or is it just the hemorrhaging?
Yeah, it's generally just the hemorrhaging. And so it's a problem in the United States where, especially seen in older Americans, people who have had a smoking history, people with high blood pressure, high cholesterol, can develop aneurysms. There is definitely a preponderance for it to be in men over women. And when it ruptures, more than 80% of the people will die, half of them before they even hit the hospital.
Now, that wouldn't really relate to what we call hardening of the arteries, the building up of fatty tissue and narrowing the veins and arteries. Is that something else then?
So the hardening of the arteries really only applies to arteries. It doesn't apply to veins at all.
But do veins build up that fatty thing on the walls, just like the arteries? Or?
Very rarely. Occasionally you will see some calcium deposits in veins in people with diabetes or kidney failure, but it's a much more unusual situation. With arteries, the hardening of the arteries is because they develop the calcium deposits. And in surgery, sometimes we'll say, oh my God, the artery's like a rock. And it is like a rock. There's calcium carbonate in the artery that makes it rock hard, whereby sometimes our needles can't even go through the calcium. And there's two processes with hardening of the arteries, or the medical term for that is atherosclerosis. And atherosclerosis can result in the development of this plaque, I call it crud, that layers inside the arteries. And either you can get a narrowing of the arteries, or actually you can get a weakening of the arteries. So you either get the stenosis you were talking about, or you get the aneurysm. And it's part of the same process.
Now, this stuff that builds in, then we're told it's due to cholesterol and eating fatty foods, but it's actually some calcium as well then that builds up in these walls.
It's not, I mean, so drinking milk does not cause more calcium deposits in your arteries. It's definitely much more related to the risk factors I mentioned: high blood pressure, the toxins in cigarette smoke, the high cholesterol, and that's what develops over time. I mean, you can still have osteoporosis and have hardening of your arteries.
And if a person has osteoarthritis with buildup of calcium, it's not related to anything building up in the arteries?
Absolutely not.
Okay. Well, how does one get a blood clot, a thrombosis? How does a blood clot develop?
Right. So when people talk about blood clots, they usually talk about clots in the vein system, not in the arterial system, but clots can actually build up or develop in both systems. The blood clots in your veins are the feared ones, where they can travel to your lungs and kill you. And pulmonary embolus, which is the medical term for a blood clot that goes into your lungs, is actually the #3 killer in the United States. And so there is a lot of awareness that has been building up about it, and that was what my talk was about this morning to the emergency room physicians, changing the paradigm of how to treat these blood clots in people's legs to something that is much more aggressive than what's been done for the last 10 or 20 years. Those blood clots develop for a variety of reasons. Often it's just related to stagnant blood. The blood just sits in the veins, and your body has systems to both help keep blood flowing and clot blood. So if you cut yourself, you expect that the blood will eventually stop flowing. And that's because there are certain proteins in your blood called coagulants, which will help the blood clot. And for example, hemophiliacs are missing some of those proteins. Some of these proteins have been found to cause hypercoagulability, which means that you're more susceptible to clot than the normal person, quote unquote. And those proteins now, there are more and more tests that have been developed, which are simply blood tests to check for those. And we don't do any kind of widespread screening for those proteins. But if you were to develop a blood clot, then as part of your treatment and evaluation, blood would be sent off for that. So there's an equilibrium in this clotting, bleeding situation, and some people are more likely to bleed, some people are more likely to clot. In addition to having an overabundance of those clotting proteins, there are other factors, such as sitting on an airplane and not moving for 8 or 10 hours that can lead to blood clots, or a long car ride, having a cancer somewhere in your body, being obese and very sedentary, and then also some collagen vascular diseases that increase your risk for blood clots.
Well, now I hear about, the anticoagulants. If, say, someone had a blood clot, I guess they do tests, right? They do the ultrasounds.
That's correct.
And if you detected a blood clot somewhere and you gave an anticoagulant, then does it move that clot where you wouldn't want it to go? Or do you go in and remove the clot, or what?
Right. So anticoagulants are important in the treatment of blood clots, and you're correct. The diagnosis of a blood clot is not done by looking at a person or a patient. It's done by getting an ultrasound, occasionally done by getting a CAT scan, but ultrasound is the main screening tool for that. Most blood clots occur in the legs, and if you have a blood clot in the leg, you will, the first line therapy is an anticoagulant. One of the most common is called heparin. That anticoagulant, it's kind of a misconception that it breaks up the blood clot. It doesn't. All it does is prevent the blood clot from moving up to the lungs and prevent the blood clot from extending, from getting bigger. If you want to treat the blood clot more aggressively, and that was what my talk was about this morning, you can go in, not with surgery usually, but with some of the new technology that's available. And one toy, I call it, that I talked about this morning has balloons on either end and kind of an egg beater in the center, and it whips around at about 70,000 revolutions per minute and actually kind of pulverizes the clot, and then you can suck it out.
So they insert it actually then.
So insert it into the clot.
So could emergency room people do that?
No.
Oh,
it has to be done by,
mm-hmm.
right, a vascular surgeon or an interventional radiologist generally in a specialized suite, because you need specialized equipment. The other technique that has been used is to simply use the clot-busting medication TPA, which has gotten a lot of press because that's what's used to treat strokes and also to treat heart attacks. And so that medication can also be used to treat clots in the venous system. Clots can also happen in the arterial system, and they're very different and actually much more serious when they happen in the arterial system. Because if you completely block an artery, then you're completely blocking the blood flow to an organ or to an extremity. And so that organ or that extremity can literally die. And so that's really an emergency. And then we often do go in surgically, though again we can use TPA or what's called lytics. They lyse the clot, and so they actually go in and dissolve the clot to treat it. But oftentimes surgery, we go in and just actually kind of pluck the clot out.
Would these things have to all be done in a hospital with special
Yes.
equipment? So it's not like you can just rush into emergency. Yeah, it all has to be planned out and arranged for these various tests and things.
No, if you have a blood clot in an artery, that's an emergency. And so you would go to emergency, and then they would call someone like me to come in emergently. And you would go to surgery or to a radiology suite within a couple of hours to get that problem taken care of. Depending on what part of the body it is, your organs and your limbs can only live for a certain amount of time without blood. And so there are very strict guidelines, for example, on when one would use TPA or when one would go after clots in people's brains. And those are on the range of minutes to a couple of hours. With the extremities, you have more time. You have generally up to 6 hours to reestablish blood flow. But it's done, you know, in the middle of the night or on the weekend or whenever it happens.
That's so sad with the diabetics who don't get that blood flow into their legs. And
that's a different problem. It's not generally an acute problem with the diabetics. With the diabetics, it's really a long-standing problem of years of this extra sugar deposition and other extra kind of factors, we'll call them, that they have. Diabetes, unfortunately, as you may know, is the #1 cause of amputations in the United States. And so it's not because of an acute block, but it is because of a complete occlusion of their blood vessels over time. And unfortunately, the blood vessels that usually get blocked with diabetics are the ones that are 2 millimeters, 1 millimeter, I mean tiny, tiny things that the present surgical techniques don't work that well on to bypass or go around or get them on. And so that's why it's the blood vessels below the knee that are mostly affected, and they lose digits and toes and ultimately their legs.
I don't know if this is a question you'd want to answer, but I recently had a friend who has diabetes, and his toe, they wanted to amputate his toe. And he was a dancer, so he kept waiting, and he didn't want to do it. And then it turned out they had to take his foot.
Right.
And then they said that he even waited too long for that, and so they ended up, well, the leg, you know, up to the groin. And I will always wonder if he had let them take that toe or even the foot early on, would it have prevented losing the entire leg, or is that going to happen anyway?
No, I think it may have prevented it, sadly enough to say. The problem with diabetes, I mean, there are a lot of medical complications of diabetes, as I'm sure you're aware. Kidney failure, blindness, coronary artery disease, heart attacks, strokes, and then the peripheral, what we call peripheral vascular things, the leg stuff. And in addition, people with diabetes, their immune system is not normal. They are much more susceptible to infections, and they're much less able to fight infections. And that's from a combination both of, you know, their blood cells and what infections they can fight, and the fact that the blood is not getting to the site of the infection because of their vascular disease, and so it can't even get there to fight it. So if they had taken, usually when you have a story like what you've told me, and they start with the toe, they go to the foot, they go to the leg, there's an infectious component in it, and they don't want the infection to kill the person, and so they cut off the infected part because the person doesn't have the ability to fight it themselves. So sometimes, unfortunately, with diabetes, infection can spread much more rapidly than in you know, people without diabetes. And it may have been that if they had just been able to take the toe, he would not have lost his leg. However, again, the problem with that is he may not have had enough blood to heal where they took the toe, the wound that they took the toe, taking the toe left. And so, unfortunately, there is this thing, or this sequence that we see more commonly than not, where you start with the toe, it doesn't heal, you go to the foot, it doesn't heal, you go to the knee, and then it heals.
Yes. I think that was some part of the problem. I wanted to ask you too about this plaque. I know there are procedures that you use to clear the plaque out of the veins and the arteries. You go in and do like scrapings, or what are some of the methods you use? I know there are stents and
so the plaque again really applies only to arteries. It's almost never applies to veins. And there are different procedures that are used, and vascular surgery has been so great, I think, because in the last 10 years there has been just a complete revolution in vascular surgery. I've been in practice here 14 years, and many of the procedures I do now I didn't really learn in training. I've had to learn since training because they didn't exist when I was in training. And I remember when I started my training about 22 years ago up at University of California, San Francisco, I would stand in these operating rooms with vascular procedures, and, you know, 10 hours, 12, 14, 16, I mean, those were not uncommon lengths of procedures. And now we almost never see those. Incisions from stem to stern, you know, were commonplace. People being in the hospital for months on end were commonplace. And now with the less invasive techniques that have been developed, you know, much of what we do is through a poke in the groin, and the person, and it's the same end result as a very large open procedure. So, as I mentioned, there's two main problems in vascular surgery. One is a blood vessel gets blocked, and one is a blood vessel gets dilated and can rupture. When you have the blockage, there's a couple of different surgical techniques that can be used. One is to do what's called an endarterectomy, and that's the most common procedure done on someone's neck for the carotid artery, where a blockage is directly related to having a stroke. And so you can decrease the risk of stroke by clearing out the crud that's inside the artery. And you actually do that with a little scoop. It's a little shovel. You open the artery, you scoop out the stuff, you sew back the artery, and that's the end of the procedure. If you are unable to scoop out the plaque because it's not in a very limited area and you have a very long blood vessel that's either blocked or has a lot of plaque in it, you can do a bypass. So on Monday, I had a gentleman who had had a stroke in the past, and I scooped out the carotid artery, and that was a very kind of nice, clean operation. And then later that day, I had a gentleman who actually had a congenital problem where one of his normal arteries didn't develop, and we did a bypass around to bring blood around the site of the blockage.
There's one other test that they take where they put dye in your veins and then x-ray.
Correct.
What's that for?
That test is called an angiogram, and what it does is it allows you to see where blood flows. An ultrasound is a great test because it is non-invasive, it's inexpensive, there's really almost no risks associated with it that I can think of. And it's a great screening test to look for an aneurysm, to look for disease in the carotid arteries, to look for valve reflux in veins, which we'll talk about a little later, and flow dynamics. So it's more of a picture of, well, functional status.
I wanted to ask you about varicosities because I see these pictures of these huge veins sticking up on people's legs and little lumps and so forth. Are those dangerous or just unsightly, and how do you take care of those?
Right. So varicose veins are not dangerous. Treatment of varicose veins is almost always an elective procedure, and unfortunately these days is becoming considered by most insurance companies a cosmetic procedure. The varicosities that I see a lot of people for bad veins, and usually there's an underlying problem with the valves in the veins. So in veins, blood flows from the foot all the way back up to the heart, and so it's flowing against gravity. And what have been developed, and I'll always say what's God's made to in these veins are these one-way valves, and these one-way valves open and close, and when you the blood is flowing through, the valves open. When you stand up and there's gravity pulling and the pressure of the blood above, the valves close, and therefore that prevents them from falling all the way back down to your feet. And they kind of move up towards the heart. In a lot of people, like 60, 70 million Americans, the valves don't work properly. And people come in to me or complain to their husbands of heaviness, aching, throbbing, burning, swelling in their legs. And for many of those people, it's because the valves don't work. And that too can be diagnosed by ultrasound.
Does it need to be fixed, or can they just live with it?
Right, they can just live with that. If you get diagnosed with leaky valves in your veins, the leaky valves are in a vein that is generally not visible. There's a straight vein called the greater saphenous vein that runs from your groin down to the inside of your ankle, and that's 80% of the time where the problem is. That vein has been treated for 60, 70 years with vein stripping, and that's a procedure done in a hospital with incisions, and you pull the vein out using a little white plastic stripper. These days, more of what people who treat veins routinely do is seal the vein closed, because again, it's a less invasive procedure. It can be done in the office with local anesthesia, doesn't require a hospital visit, doesn't require incisions, all through a puncture. And so you can seal that using either laser energy or radio frequency energy, which I tell patients is kind of like a microwave, and it's equally as effective as the vein stripping. That does not change how your leg looks. It will change how your leg feels, and 95% of the time your aching and throbbing and heaviness will be gone. But the visible varicosities will not be gone. And that's the cosmetic part. So those need to be actually either pulled out through little punctures, and we actually use these little crochet hooks. Sometimes you can even just buy them from Michael's and use that kind of a crochet hook.
Little self
And if you wanted to do it at home, or they can be injected with agents that will help clot off the vein. The spider veins on your nose, for example, the little teeny red ones, those really are best treated by laser. Most of the spider veins on people's legs, though, are purple or blue-green, and those laser generally does not do a very good job on, just because of the absorption spectrum and the wavelength of the light. And so those are treated better by a technique called sclerotherapy, which everyone knows as saline injections. However, saline is not always the only liquid that you can inject. You can inject a variety of liquids.
What's the most important thing you can tell us to do in order to maintain a healthy vascular system?
Well, the thing that keeps me in business, honestly, is cigarette smoking. So if you smoke, stop smoking. If you don't smoke, don't start. You need to keep your blood pressure under control. Take the medications that your internist gives you. Cholesterol control is also extremely important. If you're diabetic, keep the sugar under control. And if you're not, maintain a normal body weight so that you don't develop any kind of glucose problems. In addition, if you have any of these risk factors that I've talked about, talk to your primary care doctor about screening. Have them make sure they listen to your neck and see if there's a funny sound in the arteries going to your brain and that you need an ultrasound of your carotid arteries. Any male over the age of 55 who has ever smoked 100 cigarettes in their life, I think that's the cutoff, is eligible for a free screening by Medicare for an abdominal aortic aneurysm. And with people getting bigger as they age and bigger as the years have passed in the United States, it's more difficult for any doctor to feel an aortic aneurysm in someone's abdomen, and so getting the ultrasound is vitally important.
Thanks again for coming in. I've learned a lot. I wish I could have talked to you for another hour. I'm sure you could tell me a lot more, but thanks again.
Yeah, thank you very much for having me.
If you would like to contact us in any way, you can reach us through the Cupertino Senior Center. Their telephone number is 408-777-3150. The Better Part has a website. It's www.thebetterpart.com. If you want to purchase any of our programs, we have order forms on our website. And we also have many programs in the Santa Clara Library System. So thank you again, and we'll see you next time.